It's interesting to look back at the, at least the 12 years I've attended this meeting to look at how imaging has evolved. And, originally we were trying to justify all this new imaging. We called it next generation imaging, now molecular targeted imaging. And now we're having really robust discussions on how it's impacting how we manage patients, which is really complicated because all of our clinical trials didn't incorporate PSMA PET into their trials. So I think we're going to talk about oligometastatic disease, but I think it's important to establish whether or not you believe in oligometastatic disease or not. And I'll be the first to say that my belief in this is kind of waning. And I think maybe the terminology needs to change. This is a slide from Rob Reiter that he gave this amazing presentation at the APC meeting maybe 5-6 years ago on oligometastatic disease. And I was a believer. This is great. We have an opportunity to potentially cure some patients. And imaging is going to be a big part of that. I will say, though, that my belief in this is kind of waning because, as we heard about before, I don't have a PhD in engineering from the University of Michigan. I did sleep at Holiday Inn Express, and I, too, agree that using a number 5 is not enough to say. It's just too basic. It just doesn't make sense. And I think we need to move past that and kind of what Dr. Han was saying. I think we need to think more about biology. And to me, oligometastatic disease, at least in the hormone-sensitive setting, it's metastatic hormone-sensitive prostate cancer, and where are we putting it? And I think we need to think about it in terms of biology and not just number. What are the goals for treating oligometastatic disease? I think it was really nice early on to hear conversations about shared decision-making and understanding what the patient's needs are. Some patients, maybe sexual health is more important. For some patients, they just want to do anything, just to throw the kitchen sink. So I think it's important to have those discussions and figure out what options are best for those patients. And then Embark, I think, is really controversial. It was, Larry gave that wonderful lecture just before this, and I think it presents a lot of new questions. So Embark, I think they enrolled their first patient in 2015. What were you doing in 2015? I can't remember. But they sure as hell weren't doing PSMA PET routinely. They weren't doing it in the Embark trial. But yet we were presented with this data 8 years later and had to figure out this mess on our own. And I think we have some good ideas on how to manage those patients today, now with PSMA PET. So this is just one case, a 79-year-old man, post-radical prostatectomy. I'm giving a lot of clinical information just for your awareness. When we get these patients, we have very little clinical information oftentimes. This patient, this is their site of recurrence. And this comes from, this was a PYL PET. And if you used oligomet strictly, you probably wouldn't say this is oligometastatic disease, but this is sort of not typically, this isn't in the pelvis where we're usually thinking of oligomets, but this is in one area, and this is one radiation field. And I think it just presents new questions that I think we all need to think about and be more comfortable with. We've heard about METS-directed therapy, STOMP, SABR, oral. I'm going to look at it from a different perspective. This was STOMP, and as Dr. Han said, it was with choline, which is an inferior imaging agent compared to PSMA PET. And you see, the curves divide and the hazard ratio is, 0.6. But I think the other perspective on this is almost everyone's recurring. So this idea of curing patients, I don't think we're really curing. Are we getting a response? Sure. We're delaying ADT. Whether that's the right endpoint or not, who knows. But I don't know. We could be optimistic or pessimistic looking at this data. I've turned a little bit pessimistic on this. We have oral, which we saw earlier, similar, but now you're using PSMA PET and METS-directed therapy, and not that you could do sort of a trial-to-trial comparison, but I think we're getting more durable responses in these patients. One thing to remember in these trials, I don't think they really separated these based on the risk classification, whether doubling time was less than 9 months or greater than 9 months. It was just pretty much MDT and whoever qualified. So it was pretty open. So is progression inevitable? And I would say yes. And Chris Kane talked about this. Imaging is wonderful. I'm an imager. That's how I make my money. But it's not perfect. And we need to highlight the fact that the sensitivity at initial diagnosis, not very good, right? I forget who gave that lecture yesterday, but moderate sensitivity, maybe. But I would say, 40% doesn't really give you much confidence that you're catching everything. And as I talked about yesterday, it's because we cannot detect microscopic disease. And that's why, as Dr. Kane said, you do the lymph node dissection and you're going to discover more lymph nodes. BCR, so in those trials, all those patients went on to get prostatectomy. You got the lymph nodes dissected, they slice them, they could detect micrometastatic disease, and then sensitivity rates go down. In BCR, we don't have the luxury of having all that path data. So all the data that's been presented to you over the past 3-4 years has been on something called detection rate. It's not the same thing as sensitivity and specificity. And in those trials, you had very limited path confirmation of a lot of the lesions that were called as metastatic disease. And a lot of times it was just 3 readers, and if 2 to 3 agree, you call it a met, and you say, all right, good job, pat each other on the back. You detected either a local recurrence or metastatic lesion. And that's how you get these great levels of detection at low PSA levels. But you can't detect micrometastatic disease. And if these patients went on to get a salvage lymph node dissection, the sensitivity rates wouldn't be as good. It'd probably be similar, because I think the biology of the disease is probably similar at initial biochemical recurrence as it is at initial diagnosis. So I think there are a lot of lingering questions. Now we have systemic therapy options for patients with biochemical recurrence. We have Embark, patients with a PSA doubling time of less than 9 months qualified, so this is an option. You have questions about, delay in initiation of ADT. That's an interesting endpoint. That's an interesting benefit for patients. You also have treatment suspensions. So patients who were on BARC, maybe they got treatment early, but then they went on treatment suspension for, I think, sometimes 20 months or longer. And then you have combination therapies, enzalutamide plus ADT, or do you add MDT to that as well? Inevitably, I think that might happen. I think you might get these patients, you'll put them on Enza, you'll put them on ADT, and you'll also go METS-directed therapy. But we don't have any data to prove that that's appropriate. So the role of imaging in this setting, I think if you are thinking about MDT and you believe in treating oligomets with METS-directed therapy, I think you have to get a PSMA PET. I think that's been pretty established. No MDT, if you're not thinking about it, then yeah, I don't think you need a PSMA PET. That being said, I think the ship has sailed, and even based on one of the ARS results from yesterday, I think everyone's getting PSMA in pretty much every clinical setting. So I don't know if I say anything here if it's really going to make a difference. But I think we need to be, again, thoughtful, because if we start overutilizing PSMA PET in every single scenario, they're going to start cracking down on this, and in the end, our patients are going to suffer. So this was our RaDaR 6 article that talked about our recommendations for molecular targeted imaging. And it's interesting, this was before Embark, before sort of, we met maybe 2 years ago, a year and a half ago, and we gave our strongest recommendations to do PSMA PET if you're considering MDT. And I think that's actually a really, really thoughtful recommendation, especially given all the new data that we have today. So path forward, I think it's important to really think about the goals of care for every single patient. It takes time, and it's easy for me to say because I'm a radiologist and I don't have to see patients directly, at least not often. But if I was the patient, and oftentimes when I sit in the audience, I look at it from that perspective. If I was a patient, what would I want? Yeah, I'd want to sort of talk through the various goals of care. I think BCR risk stratification is something that we need to really focus on. A high-risk patient is different from a low-risk biochemical recurrence. I've no doubt in STOMP and Oriole, if we actually separated it by their doubling times, we'd probably get a more robust response in those who had a low-risk recurrence as opposed to a high-risk recurrence. Clinical trials, that's really exciting. I know Novartis has a trial. A lot of companies have trials right now looking at escalating treatments in this high-risk BCR setting. There's one trial with Pluvicto in patients with high-risk biochemical recurrence. We'll see how that turns out, but I think it's exciting. And it does make a lot of sense to try to hit these patients harder when they're healthier and maybe lead to these more durable responses. And in the end, I think shared decision-making is the path forward. So that's it, and I am ending 50 seconds early, which, Dave, I've never ended late at this meeting.